Hello, on behalf of Associated Patient Advocates, it is my privilege to present with my colleague, Shireen Honest, this discussion of the U.S. healthcare system. This is an overview designed to set up the next series of webinars, which will take various aspects of the U.S. healthcare system. Shireen has been in the business and financial side of healthcare for many, many years and is an expert on the flow of the money and the legalities. I have been a practicing physician in internal medicine for many years in the East Bay area. After I tried to semi-retire, I discovered that the need was so great for people to help patients who had become friends and friends who had become patients to navigate and understand the healthcare they were receiving, as well as the financial ramifications, that I and some colleagues founded a company called Associated Patient Advocates. On behalf of Associated Patient Advocates, which works for patients, this is our presentation on not only the U.S. healthcare system, but how we compare to the rest of the world. Thank you for listening. So let us begin. If you have ever felt when dealing with your healthcare needs or those of your loved ones, like this fellow in the picture, this talk will hopefully help you. Those equations on the board are no more complicated than the United States healthcare system. No less a healthcare economist and philosopher than Donald Trump himself came to the conclusion that nobody knew healthcare could be so complicated. Yes, it really is complicated. As an example, the Trump administration required hospitals, and it is now still a requirement, that they post their hospital prices, the idea being that consumers would be able to compare hospital prices. Bernard Wolfson is a healthcare reporter. He and a lobbyist friend of his spent months trying to compare prices from two hospitals, and between the two of them, they could not figure it out. For kicks, I downloaded a ChargeMaster, that's what hospitals call their price list, from a hospital. It was 116 pages. This kind of information is not for beginners, and it really is not useful for the average consumer in terms of trying to compare hospitals. This graph demonstrates the relative growth over the last 50 years of administrators versus physicians. The little yellow line at the bottom is the relative growth in physicians. The blue C above it is the relative growth in managers, which really took off in the 1990s. If this system were so simple that it was easy to administer and understand, you would not have seen that incredible growth in managers and administrators. This has opened up a field for patient advocates. When might you consider engaging the services of a patient advocate? If you feel that the communication between yourself and your healthcare provider is not ideal, if you feel like you haven't been heard, if you're not sure that you understand the treatment that is recommended or why it is recommended, if you're afraid you won't be able to pay for it, if you think you have insurance but you're still not sure that you'll be covered, you may want to consider a patient advocate. Many of our patients do internet research and come out even more confused. Please understand that the internet is basically a big carnival, and many of the things you will find as recommendations for care and treatment of any medical condition are really advertisements. You need somebody who can translate and understand what is genuine from what is hucksterism. If you need, or a loved one needs, to leave their home and go to a care facility or a hospital, that can be very stressful. Vice versa, if your loved one is coming out of a hospital to home or a care facility, you may need a lot of help to understand and help you manage not only the stress, but also new equipment, new treatments. And finally, my favorite reason is if you think that when you leave your healthcare provider, your dog gets better care than you do, maybe you need some help. Who are we? We are associated patient advocates. We have a multidisciplinary team of experienced healthcare professionals with a wide range of experience and expertise, which you can see on the slide. We can cover dealing with doctors. We can cover the mental health stress. We can help you with managing your illnesses. We can help you in life transitions, and we can help you understand and at times work to get either reduced medical bills or at least understand your medical bills. Let's move into today's topic. America is a very exceptional country in many ways. In terms of healthcare, we are very unusual in that America is the only developed nation that does not guarantee access to healthcare to all of its citizens. We also distinguish ourselves by having the most costly healthcare in the world, the highest administrative costs, a complex and fragmented system, as opposed to a unified system as other nations have. How did this come about? Well, it's a unique result of serendipity, political wrangling, and also an expression of our values. And we are one of the few developed nations that has a healthcare system that in many respects is dominated by large for-profit entities. What would you like to remember from this evening's session? My take-home points. A nation's approach to healthcare reflects its values. In America, we value free enterprise, individualism, efficiency, profit, capitalism, sometimes more than we value fairness, moral obligation to help our fellows, or equality. Over the years, our current situation has reflected a back and forth battle between people concerned for the common good and people who want to make profit. Other countries have other ways of doing the same thing in terms of delivering health care, except they do it at less cost, more simply, with more complete coverage, and they get better results. The United States invests less proportionately in social services and more proportionately in sickness care than other countries in the world, so that if you actually add up total spending of the two, we actually get the results you might expect. That is summarized in the American Healthcare Paradox, the book cited at the end in the references. And finally, millions of people are employed in the healthcare system, ranging from doctors, nurses, support people who deliver the supplies and stock them, to the people who do the billing, the coding, the prior authorization reviews, insurance salesmen, you name it. Several million people owe their jobs to this complex healthcare system, so that when we talk about cutting out complexity and administrative costs, understand that there will be those that are displaced and are quite unhappy. Let's talk about getting some terms straight. You will hear these again and again in healthcare debates, and we will go through these one by one. First of all, let us distinguish financing from delivery. Financing is about the money. This is how you pay for the services you receive. The simple approach being that you pay for what you get. This works out well if you're getting your hair cut or your nails done. However, when you have a bill that might be 100,000, 500,000, $1 million, or we have no idea what it might be, most of us, given that expense, would rather have insurance. And in the United States, we have multiple financing mechanisms for paying for the care that is delivered. We will discuss those in some detail. Delivery is actually providing the services, whether it's doctor visits, hospital care, x-rays, physical therapy, and some services are actually public health measures. We all expect to be able to turn on the tap and get clean water. That is something that we do for the common good. Most of us expected there would be a response to a healthcare pandemic. There was a response to the Ebola scare several years ago, and it was thankfully more of a scare than a reality. But most of us, when we think of healthcare, we think of where we go for our care. There's the dictionary definition of insurance, which all of us can read, but there's also my simple definition, which is that we pool our resources to share the risk of an uncommon, unexpected, unpredictable, and possibly catastrophic event, such as a major illness, so that one individual does not bear the entire burden of the event. And in fact, we socialize many services like firefighting, police, road maintenance, water supply, because we cannot all have our own private fire department or highway department. And obviously, the best insurance is the one that you may never use. Insurance companies are just a way to collect the money and pay out the expenses. This slide makes the point that a small percentage of the population accounts for a great deal of the spending. Great proportions of healthcare spending are accounted for by seriously ill people, especially in hospitals. The reason we have insurance is we never know if we're going to move from group 1 or 2 to group 9 or 10. The hope is that most of us will not, but you do not know that, which is why insurance becomes very important. It's also why insurance companies want a lot of people in groups 1, 2, 3, 4, 5, and 6, because these are the people who will ultimately wind up subsidizing the people in groups 9 and 10. One of the ways they do that is by mandating that everybody participate. Many of us have been terrified by the idea of socialized medicine. So what is socialized medicine really? In socialized medicine, a single entity, usually the government, but not necessarily, takes care of both the financing of healthcare and the delivery. That means it collects the money, it owns the facilities, it hires and fires the staff, it's responsible for the outcome. The best example, the classic example, is the National Health Service in England, which owns the hospitals, hires the doctors and the staff, and collects the money through taxes. However, it need not be a government entity. Historically, this has been used as a Red Scare tactic going back to the 1920s and revived actually during the McCarthy era in the 1950s. A single payer system is actually somewhat different because it only handles the financing side and not the delivery side. If you've been watching politics, you'll see that Bernie Sanders has advocated Medicare for all. In a single payer system, a single entity, usually the government, collects the money and pays for the health care, but the health care can be delivered in a variety of settings by a variety of providers, often private, and it does not, in fact, own the staff or the facilities. It merely pays them a contracted rate for delivering a service. The classic Single payer example is Canada, which actually started their own system called Medicare in 1961. Typically, because these are simple and unitary systems, both socialized medicine and single payer systems have a low administrative cost. The more fragmented the system, the more complex it is, the more different rules, the more different players, the higher the administrative costs. Most of us in the United States are familiar with employer-based insurance, where you obtain a job, the employer contracts for insurance coverage through an insurance company, often several, at some predetermined rate. Your employer will pay into the premiums. You may be asked to share some of those. The employer may or may not offer coverage for your family. If you lose your job, you obviously lose your insurance, as your dependents might. This is the dominant model for the employed population. We'll talk a little bit about how that came to occur. Depending on what your employer selects and who they contract with, there are huge variations in plans, and picking a plan from a smorgasbord can be a very entertaining decision analysis project if you are not an expert chess player, computer scientist, decision analysis expert. Then you may need to engage some help. And small employers tend not to provide any insurance at all. Restaurants and the food industry, and often hotels and mom and pop shops, often do not provide any insurance. In other countries, should you become unemployed or are unemployable, your insurance is typically covered through a different mechanism. And of course, there's always private pay or self-pay, which are hospital ways of saying the person does not have any insurance and we will send them the entire bill. So this is uninsurance. This is common in undeveloped nations where you pay for the service with cash, if you have cash. Many people are underinsured, which is you think you have insurance, but then you discover that it really doesn't cover things very well. One of the problems, of course, is that Medicare and the large insurance companies will negotiate discounted rates off the, you might call it the rack rate, like hotels have, which are discounted to those companies, but a private individual has no such bargaining power and they will get the entire bill. Medical bills are the single largest cause of bankruptcy in the United States. When Obamacare was being debated, there was a lot of talk about the individual mandate, which is a requirement that each person is responsible for participating in whatever the activity is for the general welfare. In this case, it would be that each person purchase health insurance if they cannot get it any other way. Typical of the United States is we do require insurance so that you can drive your car on the road. In much of the world, the individual mandate is a given. It's considered part of being a good citizen. And as we discussed, the larger the pool of people in an insurance plan, the less likely it is that any one of them will bankrupt the system. In fact, the individual mandate is a favorite thing for conservative economists and insurance companies because it reduces their risk. Romney Care in Massachusetts actually involved an individual mandate. Many of us are enrolled in managed care systems. It has been used by Medicaid, particularly in California and other states. It is Medicare Advantage, quote unquote, that is managed care, and it is used by health maintenance organizations and even by other more liberal private insurance plans. So what is managed care? Well, there's a dictionary definition, an encyclopedia definition, and finally, there is this lovely definition, which is the third one, which comes directly verbatim from the website of a very large national health insurance company. One word is common to all of these definitions. That word is cost. Managed care was designed by insurance companies to control their costs. They may say that there is quality as a goal, but that is really secondary. And some of us will recognize that this means that you have to see the provider who is, quote, in network, chosen by your insurance company, that there is oversight by insurance employees of your healthcare provider to make sure that they are doing what the insurance company considers the right thing. They have to request prior authorization for medications, often procedures, and you may know that some drugs are covered, but some cost more than others, and these are designed to manage costs. There are entities that are not for profit, which means that they are in existence to provide goods and services and cover their costs, but not necessarily to make extra income for their owners or shareholders. And theoretically, any excess revenue is reinvested in the company. But you can hide a lot of money in business expenses, whether it be new buildings, corporate jets, big salaries, corporate bonuses. However, in much of Western Europe, there are private insurance companies in the plans, but they are not for profit. On the other hand, in the United States, many insurers are for profit. They tend to have high overhead, but also they are expected by their shareholders to return a profit, anywhere from 5 to 15%, depending on the investors are acceptable. So let's take a little jaunt around the world and see how other countries do it. T.R. Reid is a reporter who has lived in many countries in the world, and he took a tour of the world looking at their healthcare systems under the guise of, what can you do for my poor bum shoulder? Well, Jill Quidano is a social worker who wrote One Nation Uninsured, which is probably more than you ever wanted to know about the history of the healthcare debate in the United States. So we will start with ancient times, compare ourselves with the rest of the world, and depending on where you fall in the great United States pluralistic system, you could just as well live in any of these other places in the world. Since death, dying, and illness are part of the human condition, for as long as there have been humans, we have also hoped to be well. Chinese and Indian medicine goes back thousands of years. They just discovered a relic in Finland, a healing snake stick. It goes back thousands of years. You can read the Bible, which gives a very detailed clinical description of a quarantine procedure for those suspected of leprosy. And the Talmud describes the inheritance of hemophilia. The Greeks worshipped Asclepius, the god of healing. They understood what diabetes did to you, not necessarily why. They had great healers like Hippocrates. Medical students today still take the Hippocratic Oath, and he's famous for his little maxim that every doctor knows in his sleep, which is do no harm, which is don't make things worse. However, the Romans, being great organizers, to my knowledge, are the first people who really organized healthcare, and they did this primarily for the Roman legions. As they were busy conquering the world, they realized that sick and dying legionnaires cannot fight. They brought with them their own medical corps. There was a professional medical corps that brought their own MASH units. They set up field hospitals. They brought their doctors and supplies with them. The Romans were also brilliant in terms of sanitation and public health. You can still drink from water fountains in Rome that have been running since ancient times, and the Romans also started hospitals for the public, particularly military veterans. Let's jump ahead a few years to 1883. This handsome guy in the very interesting hat is Otto von Bismarck, also called the Iron Chancellor. He was not renowned for being a warm and fuzzy guy. He unified Germany, he ruled with an iron hand, but he came up with some incredible innovations. Under Bismarck, Germany started workmen's compensation, Social Security, and a national health insurance plan in 1883, which is still used as a dominant model in much of Western Europe and Germany today. Historians will debate the reasons why Bismarck did this, whether he had many ulterior motives, which are on the slide, or maybe he was just a caring guy. In any event, we'll talk about what he pioneered. So the Bismarck system provides universal coverage and comprehensive benefits, including drug coverage, long-term insurance, and everybody is in the system. Everybody contributes a percentage of their income and benefits according to their needs. The government sets the prices. You have a free choice of plans. There are over 100 to choose from, but they compete primarily on service and depending on what industry you're in. There is an individual mandate to participate. If you cannot work, for whatever reason, the government will pay your insurance out of the general fund. So this should remind us of the US system of employer health-based insurance, but there are differences. In Germany, everybody is in. The plans are not for profit. You can pick any plan you want that exists in the country. The benefits are very comprehensive. You can pick your healthcare providers, and the great majority of the population is covered. And there's no such animal as narrow networks or high deductible plans. France is very similar. The reason I put this up is to show you that nice little card, the green card on the right. The Carte Vitale, you carry your own healthcare record with you. This is a chip card. Every healthcare provider in France has a card reader. Your medical record travels with you. The facility puts the card in the reader. They enter the information at your visit. They can review all the old records, which are on your card. When you are done with your visit, the charge goes off to the provider of your insurance, which is known to the card, and there is billing done automatically. So there are no billers and coders needed for this transaction. And when you go to a new place, they have your medical records because you bring them with you. Compare that to your experience in the United States, where you go to a new doctor or a new hospital and they ask you the same 152 questions that you answered at the last place you were at. And even if you see a specialist, they may not have the referral records that should have been sent when you may have had the referral made. So while the Germans were doing their thing and the French have their card, what have we been doing in the US? Well, Ben Franklin started the first hospital in Philadelphia. Bellevue was started as a charity institution for the poor. It's now a big municipal hospital. The big advances in the 1800s were really public health measures, clean sanitation, sewers, water. In the early 1900s, we had the do-gooders, the progressive era. Organized labor became a force. Immigrants formed their own societies, often from their own towns, primarily for sickness funds, but also burial and widows. And multiple presidents, Democratic and Republican, have all had proposals. Interestingly, Blue Cross started as a prepaid hospital plan in 1929 in Dallas. Why? Because Baylor University Hospital in the middle of the Depression needed more patients who could pay, or at least a source of revenue. So what they did was they devised a mutual aid society as a nonprofit primarily for school teachers and employee groups in the Dallas area, and this was governed jointly by the hospitals, the health professionals, and community members. Blue Shield more or less did the same thing as a nonprofit for paying for physician services, and initially the for-profit insurers were less prominent. They had obviously private ownership in government, and they have commissioned salespeople. Things puttered along through the Great Depression until World War II, which was obviously an earth-shattering event, including for healthcare. During World War II, we saw the rise of employer-based insurance for a variety of reasons. One is that there were wage and price controls. The unions had agreed not to strike. There was a labor shortage because many men were now in the military. The unions wanted benefits, but with wage and price controls and an excess profits tax, the way this was achieved was to offer healthcare benefits. In 1953, Eisenhower, as a free enterprise believer, decided to have the IRS make health insurance benefits a business-related tax-deductible expense, which essentially is a $250 billion a year tax break, primarily for employers, who will be paying, in general, somewhere like 8 to 12% of their payroll for health insurance. Henry Kaiser, on the other hand, decided that he would take care of his workforce himself. He needed thousands and thousands of workers for his enterprises, and again, sick people don't work well. So he started his own clinics on site where he became the insurance company. Out of the funds that he had, he engaged a Dr. Garfield, the patron saint of Kaiser, to hire staff. Kaiser built the facilities, they hired the staff, and they provided the services. So Kaiser Permanente now has 12.5 million members. It is set up as a nonprofit. Kaiser is both the insurance company, it is the medical group, and it is the facility owner and hires and fires people in their facilities. It would be the 6th largest state if you could put a border around it. Meanwhile, across the pond, in the middle of World War II, Lord Beveridge issued a report calling for a national health system, which became a smash. In 1946, the country was so grateful to Winston Churchill that they tossed him out of office, and Labour came in, and Bevan and his political party got the National Health Service formed. The major principles are, number one, everyone is covered, and number two is the government may collect the money in whatever way they choose, but the person does not have to reach into their wallet at the source of care. So this is socialized medicine. The government collects the money, it hires and fires the doctors in the hospitals, but GPs typically work privately in their office and are paid by capitation, which is they get paid by the head for the number of patients that they will be taken care of, and there's no reason to cost shift or try to cherry pick your customers in England because, as the healthcare minister pointed out, everybody born in England is my patient until they die. We talked about single payer. The best example of that is Canada. Tommy Douglas, who was the patron saint of Canadian health insurance, started a provincial plan which then spread to the entire country in 1961. This was indeed the model for Lyndon Johnson's Medicare, with some differences. Everybody is in the system. This is universal. The government collects the money and is the only payer allowed in the country. They pay a negotiated rate, as has been negotiated between them and the providers, but the people providing the services are private in general. It's administratively simple because everybody knows where to send the claims. There's only one address. In Canada, everybody is covered and all medically necessary services are included. This is a non-profit, publicly administered system. The book, One Nation Uninsured, goes into detail about how Medicare and Medicaid came about. In short, the insurance companies didn't want the old folks. They tended to be sicker, poorer, cost more, and less predictable in terms of their illnesses. They didn't want the poor folks because they had no money, and they also tend to be sicker than the general population. So, as part of the compromise, the private insurance companies were allowed to keep the employer-based system that they had. Medicare was devised essentially as something like a usual insurance plan for old folk. Medicaid, on the other hand, was considered a charity system primarily for people below the poverty level, and it was geared primarily for mothers and small children on welfare. There is wide discretion in every state as to who they cover, what the benefits will be, how they will administer it, who is eligible, and in California, this is called Medi-Cal. Of note, 62 million Americans have Medicare, 80 million Americans have Medicaid, and somewhere between 140 and 170 million people in the United States have private insurance. Shireen will be going into great detail on the various parts of Medicare. The short version is A is for hospitals, B is for doctors, D is for prescriptions. Supplemental is a coverage designed to pay the 20% that Medicare does not pay. Medicare usually pays 80. And then there's the quote Medicare Advantage plans, which are really private for-profit plans for the most part. One of the things I was surprised about is how amazing Richard Nixon was, because he was more than just a crook. Quote, comprehensive health insurance is an idea whose time has come in America. In fact, Nixon pioneered HMO, Health Maintenance Organization legislation, the idea being that somewhat similar to those Dallas school teachers, there would be a prepaid plan which was really invested in keeping people healthy. In terms of how it was executed, the HMO plans got millions of dollars in government subsidies to get themselves set up, and they got favored treatment because the legislation required employers with over 25 employees to offer them as an option, which obviously made them viable. Nixon also presented a plan for universal insurance, which was astonishing. It went much further than Obama did. Everybody was in. It expanded Medicare and Medicaid so that everybody, whether they had Medicare, Medicaid, or private insurance, had expanded benefits, including comprehensive care with prescription drugs, preventive care, mental health care, and nursing home care. So Obama tried to have it both ways. This was originally a Republican proposal with an individual mandate, but Obama did reform the insurance industry in certain ways, meaning that A, there's an individual mandate, which is no longer enforced financially, but you cannot be refused because of a pre-existing condition. Maximum out-of-pocket was inserted in the plans under Obamacare. You can no longer be told that your insurance only goes up to X many dollars and then you're on your own. Children can stay on the parent's plan until age 26. They do mandate covered services, including emergency room care, obstetrical care, and preventive care. And for those that don't have enough money to buy their plan and are below a certain income threshold, there are financial subsidies provided by the government so that you can purchase insurance. Medicaid was to expand. The Supreme Court, you may remember, decided that expansion is really up to the states, and there is now a market that Obamacare created for individuals to purchase health insurance, and there is a market, a small business marketplace as well. Fundamentally, Obama, however, did not change the delivery system, and it really works primarily through private insurance companies and or Medicaid. However, 20 to 24 million Americans are now insured who were not otherwise insured. You could make an argument that LBJ and Obama essentially rescued the private insurance industry by providing them with many, many customers. There are fewer uninsured, especially for the states that did expand Medicaid. And we now have maybe 5 to 10% in the expansion states uninsured, many more in the states that chose not to expand Medicaid. I said at the beginning that depending on how you access your care, you could either live in England, Canada, Germany, or Sub-Saharan Africa. We have socialized medicine in the United States. This is government-provided care through tax dollars. Prisoners are the only group entitled by law to health care, but we also have the Indian Health Service. We have medical care for active duty military. We have some care for military retirees. We have the Veterans Medical System, which is government-owned. County hospitals and clinics are paid for by the taxpayers in local communities. We have public health. We have emergency medical response. And if you want to consider Kaiser socialized medicine, where one entity collects the money as the insurance company and the owner of the facilities and the hirer and firer of staff, Kaiser basically is socialized medicine for people with a Kaiser card. We also have single payer, which is Medicare for many. That's Medicare for all, kind of like being in Canada. Medicaid. We also have the employer model, which is like Germany for the employed people. You might discover that labor always wants to get more benefits or preserve what they have. Management would like to pay less. Over time, as expenses have gone up, the employers have been rebelling. We have uninsurance, which is like living in a third world country. Because of social conditions, the poor are more likely to be sick and die, particularly during this last COVID epidemic. And there is finally an individual market. If you can figure that out, you are magnificent in every way and brilliant. This slide makes several points. Number one is not having insurance can kill you. Number two is the states that expanded Medicaid have lower proportions of uninsured than the states that did not. The states that did not are clustered in the Southeast, plus Texas, and a few Midwestern states. Third of all, there were excess deaths even before the pandemic related to uninsurance. These are pre-pandemic numbers, but the pandemic obviously made the discrepancy much worse. One of the ways to limit care is to make the deductible, the amount of money you have to pay before you get any benefits, higher, which means that the average worker, for covered workers, employment-based insurance is over $1,600 at present. That means you shell out the first $1,600 before you get a nickel paid for by the insurance company. So how are we doing in the US in terms of typical measures? Life expectancy, you might think that would count. Infant mortality, which is often used as a comparison of healthcare systems. How much it costs, how much preventable years of life lost. These are years that medical care could impact, and how the World Health Organization and other organizations rank the United States in terms of its healthcare. These are life expectancy figures from 2019, before the pandemic. As you can see, the United States does not compare favorably to Costa Rica, which ironically does have a national healthcare system, Germany, the employer-based system, United Kingdom, socialized medicine, and Canada, single payer. In fact, in 2020, life expectancy in the United States due to the pandemic went down on average over a year. And for Blacks and Latinos, it went down even more, exposing some of the social inequities in the United States as well. You might also note that somewhere around 1980, we kind of fell off the bottom of the curve compared to other countries. Yes, life expectancy is better, but other countries have improved at a much higher rate than we have. This is infant mortality. Higher is worse. We are higher than Canada, France, Germany, Italy, Sweden, and many other countries in the world. In fact, if you look all the way to the right, we are spending much more money for much less gain in what's considered preventable mortality compared to other countries. We're that big outlying line at the top. Other countries have had, yes, an increase in expenses and yes, a decrease in preventable mortality, and they kind of do cluster together. We, on the other hand, are spending more and more money and actually getting less benefit. And it's not for lack of money, because we actually spend more money on healthcare per capita than any other country in the world. Second, typically, is Switzerland. In fact, that yellow bar is meant to show that we spend more money out of the public treasury than other countries spend in their entirety. And if you look at this, a very high percentage of healthcare in the US is actually paid for with public money between Medicare, Medicaid, the VA, county hospitals, other federal and local government facilities, not to mention the fact that the public pays for the healthcare of our firemen, policemen, school teachers, postal workers, other government workers, and there's a US government subsidy from the Treasury for private insurance. You can see that most of the money actually is public money. Please recall the $4,000 excess between the United States and Switzerland from the prior slide. If you look at administrative costs in the US versus single payer in Canada, this is one estimate, and that's about $3,000 of that cost. This was published in the well-respected Annals of Internal Medicine. I can tell you as a practicing physician that we had to hire people to call insurance companies, handle pre-authorization forms. We had separate billing services, and all of these things are administrative costs at the level of the individual physician, which obviously may or may not be costs of the carrier, but they are certainly costs built into the system. There are many international comparisons of healthcare systems. This is one of them. World Health Organization classically does this. Other organizations do. If you don't see us in the first column, that's because you need to look toward the bottom of the second column. The US typically comes in somewhere between 30 and 40 in the world. If this were the Olympics, we would not be satisfied. As I said, healthcare is exceedingly complicated, and it cannot be covered in one 30 or 40-minute session. Next time, we will delve into Medicare. One of the reasons we picked Medicare is that in some ways it is the simplest of all the insurance plans. Shireen would agree. Before you can deal with the insurance system in a meaningful way, you have to learn a foreign language, which we will teach you to some extent. Shireen will then go over Medicare A, B, C, and D, as well as how to understand the billing and the statements that you get back from Medicare or any other insurer that you may possess. For those that want to learn more, I have provided a reading list This is not an exhaustive reading list. These are just some of the books that I feel could be helpful for those who wish to explore the healthcare system in more detail. Of note is that the last item, Critical Care, is a PBS special, which you can access on your channel. And the article, Death of a Hospital, right above it, appeared in the New Yorker recently. This occurred when a private equity player acquired Hahnemann Hospital in Philadelphia, a large, well-established teaching hospital that had been one of the cornerstones of Philadelphia healthcare for many years, and it is now defunct. So stay tuned for next month, which will be Tuesday, August 31st, 2020 at 6:30 p.m. However, should you have questions, we did not include the video of the question and answer session, which was relatively lengthy in the live recording. But should you have questions, you may contact us via email, which was on the initial slide, as well as our phone, which is also on the initial slide. Thank you.